Hi, this is Elliot Fishman, and this is You Make the Call. And since we have one of these cases every week, this will cover a lot of ground. So with that, let's get started. This patient has abdominal distension. This is kind of easy. There's a huge mass in the abdomen that's fat with swirls, displacing the bowel, displacing the left kidney. This is a liposarcoma. It's not a lipoma or the stranding, the mass effect. And there's no other tumor that has so much fat within it. You can have occasionally other sarcomas with minimal fat. And so my diagnosis here would be really simple, a liposarcoma, which indeed this was. Liposarcomas are one of the most common, or the most common in most cases, retroperitoneal sarcoma, although this is a classic one, which is just total fat replacement. Sometimes liposarcomas can be solid and there's really no way to make the call except saying there's a sarcoma. Sometimes they have minimal fat that makes it easier, but when it has so much fat like this, liposarcoma is not much of the differential. Patient has hematuria, and what you could see on the image on the left is blood. And then you see active bleeding if you look at the image on the right. So first thing I would think about is the patient have a tumor in the bladder, which is bleeding. If the patient had a Foley in place, you could say trauma. Other traumas can occur as well, but I don't see anything to suggest like an MVA or anything like that. So I'm going with active bleed from a tumor. You can see it occasionally from an infectious polyp, but that's pretty rare. So I'm going with tumor. And this was a urothelial carcinoma with active bleeding. Tumors in the bladder commonly bleed, but it's uncommon in my experience to see such an impressive sight of active bleeding. It's just really a nice example. Here it is on the sagittal views and on the coronal view. Again, we look at active bleeding. Sometimes I've seen patients who've had traumatic catheterizations as possibilities. Patients who've had laser therapy, you should think about that in the history. But a tumor, and sometimes the tumors are small, but look at the bleed, look at the blood clot, really nicely shown. This patient has hypertension, and so they were studying the adrenal glands to look for an aldosteroma, look for Pheochromocytoma, look for something, but the adrenals are good. An important rule is when you scan for adrenal hypertension, and you don't see anything, the adrenals are good, you have to scan down to the pelvis. You got to scan to the symphysis. One reason is there's a mass here at the organ of Zuckerkandl. We've also seen cases where patients have had masses in the bladder, extraadrenal pheos in the bladder. So this is a mass, it's vascular, and so when you ask me the question of diagnosis, I'm saying a pheochromocytoma at the organ of Zuckerkandl, which indeed this was. Beautiful example. Here's a few more images right by the aortic bifurcation, a very classic location. And again, when you're looking for a pheo and you don't see it in the adrenal glands, scan through the bladder. We've had a few cases of bladder pheochromocytoma. There's an article in Abdominal Radiology this past month which shows some very nice examples of that. And here it is in the sagittal view. You can see the tumor, a really nice case. This patient has chest pain. There's a large mass in the patient's left atrium. It has some calcification and extends to the septum between left and right atrium. Could this be a clot? The answer is yes, but it's too large. It's too smooth. It's too well defined. And calcifications can occur in clots if they've been there a long time. But based on location, size, lack of enhancement, smooth borders, and calcification, I'm thinking this could be one thing. And that one thing is a left atrial myxoma, which indeed this was. You can have right atrial myxomas, you can have myxomas in the ventricle, but the majority of myxomas are going to be sitting in the patient's left atrium. Very nicely shown here on the coronal views, the smooth margins, the calcification, and again sitting right next to that groove between the left and right atrium, very classic location. Here's just some more views showing that. And here's an intraluminal view. So we do see atrial myxomas. They will get resected. They're not going to be malignant typically, so a really nice diagnosis. Here's an incidental finding. There's a mass present, and the mass abuts the stomach. Now, you could say, just thinking about it, this could be coming from the stomach, and that's my first thought. Off the stomach, it's going to be a GIST tumor, though I've seen a few cases of duplication cysts. You can have theoretically an adrenal mass pushing on the stomach. You can have a mass from the tail of the pancreas pushing on the stomach. So you need to be thinking, where's the origin of this mass? What's the organ of origin? I would favor the stomach, and I'm going to go in a big way thinking GIST, but because it's so smooth and well-defined and water density and just a more solid, I want to exclude the possibility of a duplication cyst. So let's think about it. And in fact, this was a ciliated epithelial-lined duplication cyst. Again, more commonly, we see GIST tumors rather than duplication cysts. It's a challenging case, and it's going to come out regardless. Patient was lucky. This is a benign lesion. It'll be resected. Very nice interface to the stomach, which is typically what we associate with GIST tumors as well. This patient has sepsis, and what's the finding? Spleen looks good. There are multiple wedge-shaped defects in the liver. The adrenals look okay, so I'm thinking we must be dealing with hepatic infarcts. Hepatic infarcts can be seen in patients with sepsis. Often you'll see hepatic and splenic infarcts, maybe hepatic and renal and splenic, often multiple organs. Wedge-shaped defects in the spleen, you got to be thinking about infarcts. And so when you give me the chance for the differential, I'm going with hepatic infarcts, which this indeed was. Very nicely shown, multiple examples, sharply marginated, often seen best on venous phase imaging. You can really accentuate them very nicely with the MIP as well. A really nice example of multiple hepatic infarcts. This patient's post-trauma, and you see multiple lesions in the spleen, and that's not the appearance of splenic trauma. I don't see liver. I don't see any other organ injury. Now, if I told you the patient had multiple cysts in the spleen, you could think about that, but they don't look very cystic per se. If I told you the patient was febrile, you could think about abscesses. There are a number of things, hemangiomas, but they're usually, at least in part, vascular. One of the things we've learned over time is that an incidental spleen that's maybe enlarged, may not be enlarged, with multiple focal lesions. You don't see lesions in other organs, but occasionally you can see it in the liver as well. We got to think about sarcoidosis. Yes, in your mind you're thinking about malignancy, but the history just doesn't match. And in fact, this was splenic sarcoid, multiple well-defined lesions in the spleen, nicely shown on the coronal view. Commonly, I will see hepatic and splenic, and someone's going to say lymphoma or melanoma, and that's the way you should be thinking. But sarcoid is a challenging diagnosis, and in a patient with no history of anything else, patient had trauma, so this is really incidental in a sense. You got to think about sarcoidosis before you go down the rabbit hole of metastatic disease and the patient seeing the oncologist. This patient had weight loss. There's a mass in the head of the pancreas, somewhat vascular, somewhat well marginated. I got to be thinking this is probably coming from pancreas rather than duodenum. If it was coming from the duodenum, I would say a GIST tumor or a carcinoid. Coming off the pancreas, I got to think about a neuroendocrine tumor. It doesn't have the look of adenocarcinoma, doesn't look like a spendo. That's a possibility. Doesn't look like a serous cyst adenoma. And so I would like to see the coronal views, because when I don't see a dilated pancreatic duct and I don't see a dilated common duct, I'm thinking it's coming off the duodenum. The two tumors that come off the duodenum I mentioned are GIST And carcinoid just can be very vascular in this location. Obviously, so can carcinoid. The patient had endoscopy with biopsy, and this was a carcinoid tumor. Carcinoids of the duodenum, not uncommon, usually smaller, more likely intraluminal compared to GIST, which are exophytic typically. Here's just really nice margins. Carcinoid being a neuroendocrine tumor often is vascular. Here it is very nicely shown here. And of course, in this case, the patient was referred to us as a neuroendocrine tumor of the pancreas. And you can imagine why that indeed is the case and why that's a good possibility. But this was a carcinoid tumor. The patient has a mass in the anterior mediastinum. It's hypervascular, it's somewhat cystic, and it's large. Now, I'm not showing you the images from the neck down. If you had the images in the neck, it would be helpful to look did this arise from the thyroid gland or not. Usually you can see continuity. You could say other things, lymphoma, though it's a bit vascular, teratoma, that can be vascular and have calcifications in cystic regions, so that's a possibility. Lymphoma, cystic lymphoma does occur, but it's usually not vascular. Thymomas have a range of appearances, so in theory, it could be a thymoma. But when you follow these images upward, what would you find? And you found that it was indeed a substernal thyroid in the anterior mediastinum. Again, the appearance is usually central, can be large. Substernal thyroid can be confusing, especially on chest x-ray, but usually when you look at it at CT, it's not going to be confusing. Again, I think it's important to follow lesions superiorly and inferiorly, and in the case of what could be a substernal thyroid, you almost always can see the communication with the thyroid gland. And here is just two other images showing you the sagittal extent and how it extends upward. So again, a very nice case, and hopefully a case you can learn something from. Next case. There's a nodule to the left of midline in the anterior mediastinum. Yes, you could say this could be a node. Could it be a thymoma? I guess theoretically it could be. That'd be a pretty small thymoma. It could be a thymic nodule, though it doesn't really look cystic. If you were told the right history that the patient had hypoparathyroidism, this would be, and you would consider an ectopic parathyroid adenoma. One thing, parathyroid adenomas usually track down inferior to the thyroid or attached to the thyroid or near the thyroid, and they're typically hypervascular. This patient had a lot of symptoms suggesting that the patient had an ectopic parathyroid adenoma, as the parathyroid glands looked normal on the routine CT of the neck. So history is very helpful in this case. I will admit, if I saw this on a routine basis, I would have said, 1, maybe it's an anterior mediastinal node. 2, I can't really rule out a very tiny thymoma. So that's what I would have been thinking about. But again, this was an ectopic parathyroid adenoma. As I mentioned, they're often small, so the size is good, but they're usually hypervascular. So not the best example, but just shows you the challenges you can run into in these cases. And here it is on the coronal view. You can see the nodule right here, or that little node, but that's the ectopic parathyroid adenoma. And just a couple comments. It's fairly uncommon. Most of them are located in the anterior mediastinum near the thymus. But again, it could be other places. So it's often a challenging diagnosis, as that case mentions. Well, those are the cases, and I hope you liked them. I hope you learned something, and I hope you have a great day. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.